So good afternoon, everyone. Thank you for sticking it out to the end with us here. As Dr. Slavin mentioned, I am a neuroradiologist, so I'm not a surgeon. My name is Karina Yang from University of Chicago. I'm the director of pediatric neuroradiology there, and I'm an associate professor. I was invited to, and I'm honored to serve as the Margaret Hackett Family Program's neuroradiologist starting several years back from invitation by Dr. Frim, who's unfortunately not able to join us this year. And on behalf of the MFHP, would like to thank the American Syringomyelia and Chiari Alliance Project and the organizing committee and Dr. Slavin for including me in this conference program. So my talk is entitled A Glimpse Inside MRI of Chiari and More. So I figured it would be sort of neat to go through some of the imaging findings of some of the entities that you've been hearing about for the last several days. Okay, so for the objectives, by the end of this presentation, you will be able to explain at least 2 advantages of fetal MRI in the diagnosis of congenital CNS anomalies, list 3 findings of Chiari-2 malformation and myelomeningocele visualized on fetal MRI, describe at least 1 imaging pearl. A pearl in radiology language or maybe in other fields is just sort of a nice tip that you can learn about a certain entity. So a little imaging tip relating to conditions that are associated with Chiari malformation. Okay, so you'll see this sort of slide peppered throughout my talk. It's just sort of a pictorial outline. So I'll be covering, I guess I need a different thing for the pointer. Let's see, there we go. So I'll be covering sort of an intro to fetal MRI, and then a little bit about Chiari-2 on fetal MRI. Then we'll move on to 2 very quicker topics, idiopathic intracranial hypertension, also known as pseudotumor, and tethered cord, not fetal, just general MRI, and then the end where we'll recap. So to add a little fun to this, if you guys are interested at all, there's Poll Everywhere. I don't know if you guys are familiar. I do this with my trainees a lot, and it's easy to participate. You can either go to the website, which is listed up here, pollev.com, and / my name, Karina Yang, 867, on a laptop or any device you're holding, or you can just go to your phone texting to this number, 22333, and then you can input my name, Karina Yang, 867, and that'll help you join to the session. And I'll have that up on the subsequent slides as well. So first topic is fetal MRI. So for those of you who are not familiar, we do these at about the 20-week period. And so most patients are getting referred to us because they've had an ultrasound, of course, the anatomy scan that we obtain around 20 weeks. And there's something that they aren't seeing. Sometimes the anatomy is not visualized on the ultrasound, or the CNS system, the central nervous system, has an abnormality in it that they need further evaluation for. So then we get a referral for them to get the MRI done. There are no known harmful effects of an MRI, but we do try to, avoid it in the first trimester because we don't really know what the effects of MRI does on babies. We don't have any trials. We haven't run moms through this. So we try to avoid the first trimester, not to say that we sometimes don't need to scan in the first trimester. That said, the purported or sort of theoretical risks are that there is excessive noise. As any of you have probably undergone MRI, it's very noisy. We can put earplugs in mom's ears, but we can't really protect the baby's ears, so we don't really know how that might affect the baby. And the other item to consider is heating. When you've been in an MRI, you may get very warm eventually, especially longer that you're in there. And same thing, the baby's inside the mom with amniotic fluid around them. We don't really know the effects of heating on the baby. So that's why we try to avoid the first trimester where peak organogenesis is happening. In doing that, we pretty much make it completely safe from second and third trimester. We don't give contrast ordinarily. Every once in a while, we do have to give some contrast. It is considered a category C agent in terms of pregnancy, so we try to avoid it at all costs. But every once in a while, you do need to give it. Not as common in the neuro setting. Maybe to evaluate a tumor or something, we might have to give it. And then why are we doing it? Why do we need a fetal MRI? You have an ultrasound that shows a lot of anatomy. The fetal MRI has much better spatial resolution to look at the anatomy and pathology with. And it's helpful in terms of planning for the birth itself, and also for counseling patients in terms of having to potentially consider a termination of pregnancy if there's diagnoses or conditions that arise that may result in that discussion. And the last thing would be that it helps in planning fetal surgery. So if fetal surgery becomes applicable, that is another reason we get fetal MRI. Patients are given a written consent form that we then give them informed consent verbally, and they sign that before we give them the MRI. So fetal MRI has a number of advantages. So you think about it in terms of, different imaging modalities. We have CAT scan that gives radiation, so that's not so good when someone's pregnant. We try to avoid CAT scans. Ultrasound is safe, but has limitations. And finally, we have MRI, which is the probably best way in terms of spatial resolution to look at anatomy and pathology. So these are some of the advantages of fetal MRI here listed. First would be operator independent imaging. We are not dependent on our techs entirely to get the imaging done and to do it correctly. So when I help run these, we are sitting at the scanner with our techs. I don't know how to run the scanner, but they also don't have the full pathology and anatomy knowledge. So together as a team, we run the MRI. And in ultrasound world, the tech are your eyes. They go in the room with the patient. We don't usually see the patient. So if they miss something, you miss something because you don't usually go back to rescan the patient. So that's why I say it's more operator independent. There's still an operator helping us, but numerous different planes that you can image the baby in any which way you want. And you can see that would be an advantage because the baby is usually doing somersaults in there, especially when they're younger. And so sometimes we have to adjust the plane of imaging. So that can be really helpful to have this imaging modality. The soft tissue contrast I already briefly touched on to see things that are fluid, soft tissue, bone, pretty much anything will show up on MRI. On ultrasound, it can be limiting. Things that have air in it, things that have bone obstructing in terms of imaging wise, shadowing other structures. That can be very limiting on ultrasound. The large field of view. So on MRI, you can image the whole mom's belly. We can image the whole baby and things outside of the uterus. And that can be helpful when you don't know what the abnormality is or don't know where it is or don't know the extent, or if the abnormality is really big. On ultrasound, you would only be able to get different windows and you have to piece together the whole thing in your mind. So this way it's actually really easy to sort of see everything as an overview, and then you can focus down on something that you want to look at. Compared to ultrasound, it's less affected by maternal body habitus. So if a mother has a higher BMI, it can be hard to see through using ultrasound. And if the patient is gassy, which many pregnant patients are, you cannot use the ultrasound beam. The acoustic window, as we call it, would be difficult, and that can be hard to see into the anatomy that we desire. Fetal position. As the baby gets closer to due date, the baby's head usually engages, and then the amniotic fluid around the bottom of the uterus can be limited, and then you cannot see into the head because we need that fluid as an acoustic window. So MRI gets past all of that. We can see right through. Low levels of amniotic fluid. Some moms have what's called oligohydramnios, so then there's not enough fluid in the uterus, and that can really limit how much you can see inside. Okay. And then finally, no radiation or contrast, as you may be familiar with, is used in MRI, especially for fetal. Again, very unoften that we use gadolinium. And then no sedation is necessary. So what do we use to image? So this is very technical. You don't have to worry about the acronyms and the different sequences, but really it's just to increase our ability to see contrast between fluid and soft tissue and bone. And so we use different sequences that are fast. They're not seconds fast. They're still minutes long, but they're shorter than many other sequences that we use conventionally to do an MRI. The main workhorse is this T2 weighted fluid sequence. And so that one we use because there's fluid around the baby's brain, in the brain rather, and around the brain, around the head, around the body. There's all the amniotic fluid. So that basically serves as a natural contrast for us when we look at the imaging. There's other sequences you can use that are sensitive to blood or fat or calcifications. There's a whole alphabet soup of different sequences. And then there's even higher level things that we don't actually do it. You've seen MR spectroscopy in utero. We don't do. We do it once you're born, but in utero, we don't currently do that, but some places do. And you can look at metabolites in the brain to see if there's abnormalities. Okay. So we're going to try this one more time and see if we can get this poll to work. So don't answer anything yet. Just go to that website. I do need to activate it since I had used the other question. Last time we're going to try this. There we go. So if you go to that website, again, it's on the, oh, well, it doesn't help that I don't show it to you. You can go to polev.com/Karina Yang 867 or text 22333. Karina Yang 867, and you should be able to answer the question. Oh, now we have results. I don't know why the other one didn't work. Okay, that's okay. That was the test. It's okay when the test fails. You just want the real one to not fail. So the question was, which of the following is not an advantage of fetal MRI that we just reviewed? A was excellent soft tissue contrast. B is can image in varying fetal positions. C is you can have a dynamic type exam. D is obtain adequate imaging even if the amniotic fluid level is low. And E is no sedation necessary. Awesome. So everyone was wide awake. So that is basically a description. The option C, we can switch back. Option C is a dynamic exam that refers to ultrasound, where we can actually move the mom, move the baby, move our probe, and actually look at things in a dynamic setting. Perfect. All right. So a summary of the fetal section. This projects better when I'm at home. White text on yellow is a little different when it's on the screen. So fetal MRI is performed at 20 weeks gestation. It can aid in decisions, helping the mom and the family to decide about birth processes and also for fetal surgery potential in applicable cases. And then using fluid sensitive fast sequences is the mainstay of fetal MRI. Okay, so now we're going to move on to Chiari-2. So this is just be a series of different imaging examples of Chiari-2, but they're all going to be in utero. So they all are fetal. And you guys are all going to become experts. I'm going to help you a little. So this is the baby sitting inside the uterus. I've turned the image so it looks like the baby is upright. This is the baby's head. This is the posterior fossa. This is an eyeball. This is the mouth. Lungs here, heart in the middle, and we've got the belly down here. And the baby's probably sitting sort of like in a crisscross applesauce. So we see part of a leg, part of a second leg, and then this is the umbilical cord, this corkscrew looking thing. So I've helped you along a little bit with the pink box, correlates with the pink line of imaging, of plane of imaging, and the purple box correlates with the purple line, which is a coronal plane of imaging. So when we image the baby's brain, it's a 31-week gestation here. You can see that the ventricles, which of course are in the center of the image here, are enlarged. We use 10 millimeters as the upper limit. This one was, I think, 14 on one side and 12 on the other. So both are enlarged, a little bit asymmetrically. And the sulci are tough to see. And in the coronal plane, the third ventricle is also enlarged. So this is a baby with Chiari-2. And we'll go to the spine. So same method of orientation of the different colors and the different squares and slices. So we start at the bottom. This is the baby's bladder here. We're imaging through this level. And you can see the back of the baby. This is the back of the baby at the bottom, the lumbosacral region. We have the spinal canal, which already looks weird. It's a little bit enlarged. And then there's some squiggly gray things coming out. And these, again, are T2 weighted sequences. These are the fluid sensitive sequences. So this fluid is in the bladder. This is the fluid that's amniotic fluid. And you can see something coming out of the spinal canal. And there's definitely no skin or anything covering this. As you go up higher, you can see the tip of the conus and a sort of similar fluid filled structure behind the baby's lower back. This is the level of the kidney, a right kidney, a left kidney, and this is to show the spinal canal, which I know may look a little blurry, but I promise you this is the spinal canal sort of closed. We no longer have that opening we were concerned about over here. And higher up, you can see the cord a little bit better. I think probably we need a little less light in the front to be able to see some of these findings. When we present in radiology, it's always like pitch black. So I'm not used to all these wonderful chandeliers. And so there's a cord here, a little bit of a cord, and you'll see that is entirely enclosed. So we don't have any further outpouching of the thecal sac up high. So that was the same child. This is a companion case, so a different child, 28 weeker. Same thought process with the lines to help you. And so this is the baby's brain, and we're imaging a little bit angled so we have more of the posterior aspect of the lateral ventricles, and you can see them again being dilated. This is a T1 sequence. So now we're moving away from that fluid sensitive. I think I didn't have a great shot of this on T2, so I thought this might be a nicer way to show it. So T1 is sensitive to fat. So things that are fatty, including mom's abdominal wall, is going to be bright on T1. And things in the belly like meconium that's in the bowel, that's also going to be T1. So we have a few ribs here, baby's upside down. These are vertebral bodies. the portion of the lumbar spine probably here. And hopefully you can appreciate this outpouching that's along the lumbar region, where the arrows are showing an outpouching of CSF, which in this case is dark, just like the amniotic fluid. And we see some squiggles in there, which again are neural elements. And then this is the coronal plane. This is like staring at the baby sort of right in front. You can see a couple lungs. You can see some abdominal contents here. This is the spine curving slightly. The legs are out of the picture. And we have, this is not the bladder. This is part of the spinal canal outpouching like this with, again, some lines in there. Sometimes you can get artifact, but I'm pretty sure on a different slice I can prove to you these were some neural elements sticking into the fecal sac. So obviously beyond the confines of the spine, let alone the confines of the body, then this is abnormal. So this is a myelomeningocele. Another case, a younger baby. So you'll see the difference now, a 21 weeker. Much harder to see the anatomy. Everything looks a little blurrier and may not be as clear. The baby is moving here, which is why the ventricles are a little blurry. But in this case, cutting through this way, this is the baby in profile. This is the back, again, showing sort of a blurry version of something not quite right here. There's a defect in the spinal column and this overlying tissues. And you see enlarged ventricles, and same here, a closer up picture of the spinal canal sort of just opening up to the back, to the posterior aspect of the spine through the soft tissues. This is a companion case, 35 weeker, and we have different sort of plane, a little more obliqued, and again, enlarged ventricles, and open back. This is in the lumbar region with the bladder in the center. This is the genitalia in the front. That helps orient you. And this is lumbar spinal canal opened up to the back. So again, spinal canal looks like it's opened and it continues out and there's nothing covering it. So again, another myelomeningocele. But this one is a 35 weeker, so you can actually see the anatomy a little bit better. It's clearer because the baby's getting older. Going down just 1 week, different baby. 34 weeker. And this one, the baby is sort of sitting in front of you in a coronal plane, but we have the baby's head is turned. So we have profile of the baby's face. And then we have the spinal canal at the bottom. The legs are out of the picture, so you can't really see them. And this is the bladder up here. You can see outpouching of CSF with the spinal canal, the cord in the middle there. And then further down, you can see a larger portion of the outpouching with neural elements, again, linear areas coming through. And I liken this to like the sitting on the copier view because you're sort of getting the bottom view. So these are the two legs. Here's a thigh, here's a thigh. So just to orient you, so he's sort of upside down sitting on a copier. But it's otherwise a little bit confusing to look at because the bladder's over here. You're like, what's going on? Okay, so Carrie, just to summarize the brain imaging findings, small posterior fossa, as we can see here. These are amazing diagrams we get from StatDX, which is an online program for radiologists. Herniation of the cerebellum, downward, of course, you're familiar with. Fourth ventricular compression, we can't see the fourth ventricle, it's effaced. Cisterna magna is back here, that will be effaced. Effaced just means that you can't see it. Third and lateral ventricles are enlarged. There's ventriculomegaly, which is not depicted here. Callosal dysgenesis, that means your corpus callosum, that big white matter tract that bridges both sides, will be misshapen or too thinned in an area. And then an enlarged massa intermedia, that's this big round thing here, oval thing. That is a thick band of tissue that runs between your thalami, and so that will be thickened. Cervical medullary kink and spur, that's sort of at the bottom of our image here, that can be more subtle, and a tectal beaking, which both of those can be difficult to see on a fetal MR, more likely seen on the postnatal MR. In terms of the lumbar regions, myelomeningocele, which you've already reviewed from prior talks, the spinal dysraphism, which can come in the different flavors that you're familiar with, the spina bifida occulta, where there's nothing defective in the soft tissues, just the bone can have a defect in it. The meningocele, where you have meninges sticking out, which does not include neural elements. And then the myelomeningocele, which has the CSF and the neural elements going into the pocket. You can have abnormal elongation of the spinal cord. So the cord will go below where we normally expect. The normal termination is L2, L3. So it can go low and then it can stick dorsally on the back to a placode with a large CSF filled sac. And 90% of these patients with myelomeningocele, as you know, have Chiari2. So this is the last companion case. This is a 38-weeker. So our definition of term is 37 weeks. So this is already at term. This progresses, I think the bottom is cut off, but this is 1, 3, and 5. So it goes from 1, 2, 3, 4, 5, 6, and this is the far right. So we're going from left to right. And as you can see, this is the baby's lower sort of lumbar region in profile. I think this is the bladder here. Yes, this is the bladder. And so you can see there is a large outpouching beyond the skin surface of CSF signal. And here you can actually see the gap. You can see the hole in the distal spinal canal. It just opens up into this space. Here you can much better see, I think, some of the the nerve roots and neural elements going into the outpouching. And that's sort of a smaller central outpouching with the larger area surrounding that. And then the far right, there was this giant CSF filled sac. So sort of the extreme version of Chiari2 with a myelomeningocele. Okay, we're going to attempt this again. So if you guys haven't already, this is the Poll Everywhere, pollev.com, and then, or you can do the texting version. Okay, it should be live for you now to enter. So the question was, which of the imaging findings of Chiari2 myelomeningocele is most likely to be missed, not seen, missed on fetal MR? And the choices are A, downward herniation of cerebellum, B is effacement of cisterna magna, C is spinal dysraphism, D is tectal beaking, E is abnormal elongation of the spinal cord. And you guys can enter. There you go. I have no idea why that test one just never worked. There we go. So now we can see your live answers. I'll give you a few seconds for that. Perfect. Looks like you guys are going for tectal beaking as the more popular choice, and that's absolutely perfect. So we can switch back. The tectal beaking, as I said, can be seen on MRI, but prenatally can be really tough because it's just such a small feature. All right. So just a quick touch on treatment, which I'm sure someone else has already covered, but just in terms of sort of fetal-related issues, myelomeningocele is classically repaired in the first 48 hours after delivery, trying to decrease the risk of infection, and there's various ways that they can close the defect. If there's hydrocephalus, they'll try to do CSF diversion in 80–90% of patients. Majority of them are in the neonatal period, and 10 to 20% do not have hydro, so then that is not an issue. Myelomeningocele repair can be considered in the fetal setting. It reduces the need for shunting, can improve neurological outcomes, and so the fetal aspect of it comes from the MOMS trial, which you guys are probably familiar with, the management of myelomeningocele study that was in 2002. And so fetal surgery has been deemed not beneficial after 25 weeks, but at a center such as Lurie's that has fetal surgeons, they can actually consider doing that surgery if it meets the criteria. Okay, so summary, I think we covered all this. I might just sort of really quickly go through. Yeah, I think we covered it, so I don't think we need to reiterate that, but that was just to summarize the Chiari2 and myelomeningocele. So we'll move on to IIH. This is idiopathic intracranial hypertension, 7-year-old female with headache. This is a little girl that has a empty sella. So this is where your pituitary gland lives, and it sits in this pocket. And this, I'll show you an age-matched normal. It's too shallow. There's not enough tissue in it. There's very little pituitary tissue for the gland for a child of that age. These are dedicated orbital images where we're looking at the globes, the eyes, and you can see this is a special sequence. We normally look for infarcts or strokes on this sequence, but you can actually look in the back of the eye and see bright signal. You can see how it's bright in the background of the dark eye, and it's dark on this one. And that means there's actually restricted diffusion at the optic nerve head. The elevation of the optic nerve head, which I'll show you on the next slide, actually also has restricted diffusion. It's called restricted Brownian, free Brownian motion of water, but it is a sign of IIH. This is that dilated optic nerve sheath. So these are the globes. This is the brain with the optic nerves coming forward. And you can see the optic nerves are a little windy. They're not straight. And there's fluid in the sheath that's dilated. And then you can see the globes are flat here. They don't look perfectly round. There's a flattening. And on the subsequent one, there is a little puckering. I don't know if you can appreciate that. It's a little tiny dot that comes into the globe. So those are all signs of elevated pressure. On post-contrast, this is a T1 post-contrast image where we make the fat dark. It's fat saturated. You can see this little dot of brightness. This is the pre-contrast, showing that nerve head is elevated or enhancing because there's papilledema. So this is the equivalent of when your doctor takes the ophthalmoscope and looks in your ear and there's an elevation to the optic nerve head. They see papilledema. This is what I see on MRI. Okay. And then just to remind ourselves that in IIH, we need to get venous imaging because sometimes venous abnormalities, stenoses, there's a clot or there's a tumor potentially that extends into the sinus. Those can cause IIH as a secondary cause. There's a lot of other causes that are medication related, but venogenic is one of the known ones. So we usually get an MRV to make sure it looks normal. So in this case, this child's MRV, an MRI of the venous system was normal. These are normal looking veins. So this is a recap of all the imaging I just showed you. Again, just reemphasizing the straight versus the curvy optic nerves and all the different things I just toured you through the brain and the orbits, and also known as, of course, pseudotumor cerebri, as I mentioned. This is the pituitary gland I promised you. This is the normal age-matched normal. She's 6 years old, and you can see how much gland there is, versus this child has very little gland in the cella, so there's increased pressure compressing the tissue. Treatment, of course, is with acetazolamide or a therapeutic LP. So those are usually performed by neuroradiologists. So summary of imaging pearls for IIH. I think we just went through all the imaging findings, so I won't reiterate that. And then just to remember to check the MRV for venous issues. So the last topic is very brief. It's tethered cord. I actually did some research on this with Dr. Frim and my colleague, Dr. Ali, who's a head of spine imaging for our group. And it was on MRI in the prone position. I don't know if any of you have had prone imaging done, but in the diagnosis of tethered cord. So if you guys are interested, this is in the JNS Pediatrics back from 2018. And this is the link down here if you guys, I didn't realize that the bottom of the slide would be cut off on the imaging, but this is sort of the basic premise of our study, that looking at, this is the spinal column, the vertebrae are on the left, the spinous processes are on the right. Looking at the spinal canal, the blue arrows are the entire width of the spinal canal. That's your denominator. This red arrow, double arrow, denotes the distance between the ventral aspect of the conus, the tip of the spinal cord, to the front of the spinal canal. And then when we flip the patient at the end of the whole MRI, we flip them so they're laying on their tummy, and we scan them in the prone positioning, and we remeasure that distance. And normally in patients that don't have tethered cord, the cord will flop forward and there will be some motion. And so what we discovered was this is a patient with, well, we didn't discover it. This is a known entity, but we looked at it more closely. The patients who have no issue of tethered cord, the cord flops forward. So this is supine, this is prone. You can see the conus coming forward in the space of the thecal sac. This is a patient with tethered cord. The conus is here, it stays here. It does not move. So then what we did was do more quantification of this, looking at tethered, retethered patients, and then the other category was non-tethered patients. And we were able to figure out that there was a threshold in terms of the percent change in motion when you flip the patient to prone, that 10% was our key, was the sort of threshold that we utilized to determine if someone is tethered or retethered or versus not tethered. And the sensitivity was near 93%, specificity was 100%. So that was just a very quick sort of imaging tidbit on tethered cord. So prone imaging can be utilized to help determine cord tethering, but also in cases of postoperative retethering, and 10% is our magic canal width that we look at. So this is our last participatory question. Again, to go to text polev.com or text the number. And the question is, which of the following is an imaging pearl you just reviewed? Let me activate my thing here. Now the question should be active. Okay, so that gives you all the choices. A is for IIH. Make sure to obtain imaging of the intracranial veins. For tethered cord is B. The threshold for ventral cord motion, which is most sensitive and specific, is 15%. C for IIH, look for a full sella. D is for tethered cord prone imaging is not helpful in determining possible retethering. And E is for IIH, look for concave optic nerve heads. Awesome. I think the majority of you are going for A, which is make sure to obtain imaging of the intracranial veins for IIH. So that's perfect. The other ones are wrong. The threshold is 10%. For IIH, we look for an empty sella rather than a full sella. For tethered cord, prone imaging is, of course, helpful. And for IIH, we look for elevation or convex optic nerve heads. Okay, we can switch. Perfect. And so, yeah, just some take-home points. Again, I think we just sort of went through all this. I won't re-say much of it. I think probably the more important point is the utility of fetal MRI in a lot of these entities. So this is the information for Margaret Hackett Family Program. In case any of you are interested, you're welcome to contact us. It's a program, as you know or may not know, is available to help patients and families with CNS congenital anomalies sort of navigate UC Medicine's system and resources and establish connections. So. And that's it. Thank you for your attention. And my work email's at the bottom in case you want to talk to me.